Claudio, you have reached quorum if you want to start the meeting.
Yes. Thanks, Melissa. Welcome, everyone. I'm going to acknowledge that the time is now 10:31, and I'm going to formally call the meeting of the Tobacco and Health Trust Fund to order. I want to thank everyone for being flexible and making sure that we get quorum for this very important session of our board, where one of the big topics, in addition to hearing some of the initial data and evaluation of our programs, is to make sure that we approve the funding allocations for our new deposit of the 12 million plus some residual interest and unspent balance from a previous round. So it's a very exciting day where we make consequential votes on both those items later on in our agenda. And with that, I'll also remind people that CTN is covering us live today. So I would ask that if you could introduce yourself before you speak so that people can follow the conversation. And if you please stay muted if you're not talking, that'll help avoid some of the background noise and distraction that we hear in the background sometimes. So with that, I'm going to ask Melissa to take roll and confirm that we in fact do have quorum so that we can proceed with taking action at today's meeting.
Thanks, Claudio. So Claudio Gualtieri.
Here.
Robert Boris.
Here.
Aisha Clark. Dan Foley.
I'm here.
Samuel Hahn. Tony Harp.
Here.
I'm going to circle back to Aisha Clark because I think I just saw her join. Aisha.
Present.
Thank you. Let's see here. Cindy Harrison.
Here.
Stephen Hernandez. Suchitra Krishan Sarin.
Here.
Matthew Jasinski. Deputy Commissioner Lisa Morrissey.
Present and accounted for.
Thank you. Good morning, Deputy Commissioner. John McCardle.
Here.
Christopher Moran.
Here.
Michael Rell cannot be here today. Tricia Roscoe cannot be here today. Andrew Salner.
Here.
Okay, is there anybody who joined since I called roll whose name wasn't called? Hey, you're all set, Claudio. You have quorum.
Thank you, Melissa. So next, our meeting agenda item is to review and adopt our meeting minutes. You all should have received in advance of today's meeting the minutes from our April 24th, actually April 22nd, 2026 meeting. Hopefully you all had a chance to review those, make sure that they're correct and consistent. I will now entertain a motion to adopt the minutes as submitted to the board. Do I have such a motion?
So moved.
I think Dr. Salner, I heard first, and then if I can have a second.
Second.
Well,
Second, Aisha.
Aisha seconded. So the motion is properly moved and seconded. Are there any discussion on the meeting minutes? Any requests for edits or changes to the meeting minutes? Seeing none.
Claudio, I was not at that meeting, so just FYI, I don't think I can.
Okay, so good call out, Suchitra. Let's. I will ask for a verbal vote, but we'll also take those that are going to abstain, so you can be voted in the abstention for that.
Okay, thanks.
Okay, so all those in favor of approving the minutes as submitted, please signal by saying aye. Aye.
Aye. Aye.
Any opposed? And those abstaining?
Yes, me.
Suchitra, we will note you as abstaining from that vote. Thank you. All right, with that, I want to just talk through the goals of today's meeting. I previewed some of the big agenda item at the top, but just to sort of walk through, the Appropriations Committee has asked that the board get into a regular cadence of submitting our allocation plans in October. And in order to hit that recommended timeline, we're taking action today to begin the process for voting on the approval of the allocation amounts, the percentages across the CDC recognized categories. And that will tee up our ability to draft the narrative and the formal allocation plan, which we will be setting around to the board in September for your review and comments, with the goal of getting a finalized allocation plan to the legislature in October. The legislature then has the option, of course, to hold a hearing and vote on it, or to accept the report, not take action, in which case, after a certain period of time, it automatically is deemed approved. So for today's meeting, we're going to look at those allocations and the breakdown of the funds. We're also going to orient the board on some updates of the status of contracts from the FY23 and FY24 allocations. We're going to get an update from our project evaluators. I know that's been a very particular interest of this board as we try to guide our decisions and investments based on the ROI and the best available data on where we're actually making the most impact. So hearing from the evaluator on some initial assessments that they've done and how they plan to approach moving forward, what they're going to measure and how they're going to keep the board up to date to make sure that our dollars are spent effectively. And then we'll talk through, DBH will give us, again, a quick update on the contracts, and we'll talk through next steps at that point and close out the meeting. So with that, I will turn it to Deputy Commissioner Morrissey from the Department of Public Health, who's going to give a status update. But I think before she does, she'll also introduce some new colleagues that have joined DPH and will be part of our work moving forward. DC Morrissey.
Thank you, Claudia. Thank you, everyone. Good morning. And so before I get started with our slides, I just want to take a moment to acknowledge all of the DPH staff who are on this call and who are going to be new to the task force. And some of them you've met before. But before I go through the core team for tobacco, I also want to acknowledge Maura Fitzgerald, who is our Chief Marketing and Communications Officer, who's also on this call, Miriam Miller, who you all know from the Office of Policy and Strategic Initiatives, Ellen Blashinsky, who is working with me with the Community Family Health and Prevention Branch to do some strategic planning around the remake of some of the initiatives that we have happening in there. Francesca Provenzano, who is the new acting branch chief for the branch. And then Fran has several people on her team who are actually directly involved with the Tobacco and Health Trust Fund. And I'll let her introduce those folks.
Good morning. Someone new to our team, I think she could raise her hand probably, is Kimberly Martone, who's going to be spearheading Tobacco and Health Trust Fund work at the Department of Public Health. She came from OHS. And then we also have Amy Maritzi on the call, who I think you're all familiar with. Amy has been a long-time manager involved with Tobacco and Health Trust Funds. I think that rounds it out. Am I missing anyone, Deputy Commissioner Morrissey? Oh, Sruthi Abrapudi, who is our epidemiologist, who will be presenting on some data. Thank you.
Right, thank you. All right, thank you for that. So if we're ready, we can go ahead with the slides, and I will start to walk us through. Next slide, please. Thank you. All right, so I think most of you are familiar with how I do these. I'm just going to do a broad overview of where we are with some of the contracts in progress and just go back. The full detail for all of these are going to be as part of the package that you all receive. So you'll see more detail there, but if there's any specific questions that you have, I'm very happy to answer those now, or you can send those through OPM and we're happy to provide more detailed response in that manner. So this is just a broad brushstroke overview, a wide summary of the fiscal year 23 and 24 contracts. Very pleased to report that all but 2 contracts have been executed. We have 2 that are pending that have an August 1st start date. And then we'll be talking more about those as those come online, and we'll share some more details about that work that's happening there. Next slide, please. And then this is just a reminder, more so of the fiscal year 23 contract summary. I think quite a few of these you have seen, they've already done presentations directly to the board. And then there are a few more that we're looking to have come on so that you can see some of the work that they're doing. Next slide, please. And I'm happy to stay here if anyone has any questions. Otherwise, I'm going to move past this one pretty quickly as well. When you look at the slide deck, you'll see that there's a column that refers to what step that they are in the process. And this slide is just that summary, just to remind you where they are in the process. So if you see something that says step 5, that's just so that you know that it's now out for those initial signatures and that's indicating that it's moving pretty close to execution. Next slide, please. Great, thank you. And then just going to just spend a little bit of time on 3 items here that I wanted to just bring to your attention. So I had mentioned previously that there are 2 contracts that are awaiting execution for with a start date of August 1st. You'll see that in the 2nd line, and then in the 6th line, those are the 2 pieces there. They're both at step 4. And then the other piece in here that I just wanted to just remark, because I had asked the team why is it grayed out? I think a couple of us that. So you'll see that the American Lung Association is in gray, and the reason that it's in gray is because it's a 23 and a 24. So they just wanted to make the distinction that it wasn't solely based in 24. So just wanted to highlight that. And then I don't believe we have another slide. Do we have one more slide on this?
That's it.
All right. So I went through that pretty quickly, but happy to take any questions. I know that the star of the show are usually the contractors that we bring on to really talk about the work. So I try not to spend too much time going through the administrative, but like I said, happy to answer any questions that come up.
Thank you, DC Morrissey. I think you did a very effective job. I don't see any hands raised, but I'll pause for a second if anyone wants to ask a quick question. And of course, we appreciate that you provide that extra detail that we can dig into offline with the backup documents.
Thank you.
All right, seeing no further questions or comments, we'll move to the next agenda item, and I'll introduce Sharika Rose, who will talk through and report out on the Tobacco Trust Fund account balance and share some slides on the interest accrued to date and some DPH disbursements. Sharika.
Great. Thank you, Claudio. Here is a snapshot overview of our trust fund account balance and drawdown report as of July 2026. Within the table above and reviewing from left to right, here is a breakdown of fiscal year 23 and 24 approved allocations totaling $26.3 million, the amount awarded totaling $23.9 million, the amount not awarded for FY24 totals $2.4 million. To date, a little over $15 million has been drawn down by DPH, leaving $8.8 million remaining of awarding funds to be expended, and $11.2 million is the current remaining balance of approved allocated funds. Now reviewing the table below, this details the remaining allotment balance and the accrued interest to date. Again, $11.2 million is the total remaining allotment from FY24. Below that shows the breakdown of accrued interest for each quarter, which includes the most recent interest earned during quarter 3 and quarter 4, highlighted here in yellow, for a total of $1.4 million of accrued interest. With that, the total ending balance is presently $12.7 million. This concludes the account balance and drawdown report, and I'll turn it back over to Claudio.
Thank you, Sharika. That's excellent. Appreciate it. Any quick questions or clarifying points? Yes, Representative Harrison.
Thank you. Can clarify, I know we had an allocation in 24, then we skipped the allocation for FY25, if my memory serves me correctly, and we're due an allocation for FY26, is that correct? Doesn't that allocation show up in April?
So typically, yes, you're right. Typically that gets credited and recognized in April as part of the revenue estimates. It often takes as part of the finalization of closing down the budget, where it's actually transferred in post to the OPM account, will lag after that. So yes, it's been sort of recognized as being credited for purposes of our board in the late spring, and we're awaiting final action before year end of the books closing for FY26, where the comptroller will formally credit it to our account. We suspect that'll happen in the next maybe month or two. Usually before September is when they close the
Okay,
books.
thanks for the clarification. So we should, in addition to the 12 million that she's just presented to us, we should be getting another 12 million. Am I correct?
Sharika, I think
I'll
that you
pull that
were
back up.
also accounting
Yes.
for the fact that some of these are encumbered through projects. So it's money that still is not out the door, but has been spoken for largely. Isn't that right?
That is correct. The 11.2 million is still allotted. It's from 2024. And then we have the accrued interest. That is the total of the 12 million. 0.7, and the 12 million that you're speaking of isn't currently showing here because it hasn't yet posted to the account, but that will be in addition to.
Okay, perfect. So the 12 million, maybe outside of some of the interest, has been encumbered.
Yes. 11.3 million roughly of that is encumbered through the FY23 and 24 plans. And we're still hoping, as DPH works through the final contracting, that those can all be expended. So money is still to go out to community, but it's not available for us at this time to sort of reallocate.
Okay. I just want to make sure my recollection was correct, and I want to make sure that we're spending the money because, as you know, Claudia, we want to make sure we do that right. Thank you so much.
I love having a couple former appropriators on this panel, always keeping us honest and sharp with the state dollars and the accounting. Both you and former Senator Tony Harp are very helpful in that regard.
So, yep, thank you very much.
I see Anne, and then next Suchitra. Anne?
Thanks. I actually had a different question, Claudio, but I did want to follow up on that previous question because now I'm confused. So when we send our allocation plan to the legislature, are we sending a plan for 12 million or for 24 million?
Not for 24 million. The plan that we'll produce, and I think we have this later, is going to be the 12 million of newly deposited money plus interest accrued. So 1.3, 1.4, maybe by the time we actually submit the plan, plus any unspent balance, which we're anticipating about 2 million of cessation that was unspent for the last plan. That's as a result of the evaluation committee of the board determining that we need a little bit more data, and they weren't necessarily wowed by some of the applicants that came in. So they thought it prudent that we hold back and not fully allocate, not fully contract for that full amount. So it's going to be, Sharika, Melissa, maybe you have it off the top of your head, roughly about 15 million.
15.
Will be,
Yep.
Yeah.
Okay. So my question actually was that the table uses both allotment and allocation, and I just wondered if you could speak to the distinction there.
So I can pretty much the slide that I just showed is what's current in the account. So the 12 million you're not presently seeing there because it's not presently in the account, but we will be showing us presentation a little bit later on the breakdown of what's actually going to be for the FY26 allocation plan.
Great. So but my question is that on that table, you use in some places you use allotment and some allocation, and I just wondered if you could for everyone's understanding with the distinction between the two.
Okay, so here we have on the left the 26.3, which was allocated. And
okay, meaning that the money was appropriated to the Department of Public Health for their use.
Correct.
Okay.
Yes.
Okay. And so then down below where you use allotment, the distinction there is that it actually came to the department? Is that
No.
the distinction there?
I think it's
Sure.
best, and because your question, oh, go ahead, Melissa, do you want to take, or I'll
No,
start maybe,
yeah.
and you can.
Yeah, go ahead, Claudio, and
Okay.
then I could, because it's a pretty clear answer. It's just one is the money came from the master settlement at the comptroller's office to us. That's the allotment. The allocation is what was RFP'd out and awarded to grantees.
Oh, okay. So the allotment refers to what was allotted to grantees, not to, okay.
The allocation is what, yeah. So yes. Yep,
Okay.
that's the difference.
Thank you.
Thanks, Melissa.
And maybe we could just have a footnote sometime about that, because that could be confusing, because I know there are allotments to state agencies as well.
Well, that's what that's a good point. So Sharika, we can do that, because allotment means what the comptroller gave to our account, the trust fund account. Allocation is what we granted, I believe. Yeah.
Okay, so that's just the opposite.
It's the
what you
opposite
just
of
said.
what you were saying. Yeah, the opposite.
So yeah, I guess a footnote would be really helpful in that case. Okay,
Will do.
thanks.
Okay. Thank you, Sharika.
welcome.
Suchitra, did you have a question related to that? We can
Yes,
keep the
sorry,
chart
I
up
didn't
if
mean
so.
to. I didn't mean to raise my hand twice, but I just have one question, which is, so this new sum which is going to come into this account of the 12 million, if we get it, that's going to be a separate set of funds that will have a separate RFA, and we'll be making determinations all over again in terms of how that money is to be spent, or is it automatically just added to the decisions we've already made?
Great question. First, I'm going to acknowledge that Representative McCarthy-Vahey joined us, and that caveat that you put in, if we're going to get the money, because of her great leadership and legislative support and championing, it's a guarantee that we've closed the financial books, and it's just a matter of transferring the allotment. So that money is secured and legislatively mandated to be deposited into the trust fund for our investment. So that's good news. Then, in terms of your other question, yes, today's exercise at the end of the agenda is to frame up the new allocation plan with those new $12 million plus interest accrued since the last allocation plan, and put forward for the legislature's consideration in October a new process by which we would RFP that roughly $15 million.
Thank you.
Great. So having concluded that part and the trust fund balance, I'll thank Sharika and Melissa for talking through the finances on that piece. And we're going to go back to Deputy Commissioner Morrissey, who's going to introduce a set of 3 awardees that have different presentations on the type of evaluation and data collection that we're going to do. And this has always been a top priority. It's also a top priority of mine. So I really appreciate DC Morrissey that you've curated some good speakers today, because at OPM, we really like to lean in on data-driven budget and decision making. And I think that having the data is going to really help both strengthen and target where we make investments to get the most impact in the community, but more importantly, I think showcase for the broader legislature and policymakers that this is really a good down payment and investment on population health. So thank you for teeing up this substantive part of our agenda.
Thank you so much, Claudio. And to the larger group, I just want to say, so Claudio was alluding to the fact that we recently discovered that we both share a common language and love and evaluation, and being able to demonstrate that when we do get these funds and that we're able to put it to use, not just because we can say that, we were able to do these investments, but what did the investments actually accomplish? And that's really what the heart of evaluation is, right? It's the return on investments that we're making directly into Connecticut communities. And with that, I'm pleased to introduce Mary Beth Conroy from iPro. iPro has presented before to this group, and so this is an update, and we're looking forward to seeing some of the metrics that they've been able to curate for us today. Thank you.
Thank you, DC Morrissey, and good morning. Thank you for the opportunity to present today. Will the department be doing the slides?
I can pull them up for you.
Okay, thank you so much. Good morning, and thank you so much for the opportunity to present today. When we presented in January, I discussed the surveillance and evaluation structure for component 4. And today I'm going to focus more on how that structure has moved into active implementation, what we've built, what we're beginning to learn, and how this work is supporting the accountability, equity, and decision making for Connecticut's tobacco control program. So today's update for the board focuses on 5 areas: the progress on our program evaluation and our work plan, our data collection activities, some of our early findings, and the priorities for the months ahead. Our 6 objectives here define our role across the program coordination, providing technical assistance, reporting, evaluation planning, analytics, and quality assurance. In January, I described to you our year 1 was building our evaluation infrastructure. And this slide shows that infrastructure is now in action. Our goal is not only to collect the data, but to create a system that is providing credible decision-ready findings over time. Overall, our implementation is on schedule. Our evaluation plan has been approved by the department. All 6 work plan objectives are underway. Year 1 evaluation plan reviews are now complete, and the new contractors have been successfully onboarded. Dashboard development, data collection, and new evaluation tools are all progressing as planned. And collectively, these efforts establish the infrastructure needed to produce that comparable data across the wide variety of funded project grantees. Over the last quarter, we've reached several concrete milestones. We've done multiple contractor evaluation plans, advanced through both the review and the department's approval. We've onboarded continued new contractors. Our dashboard development is continuing to move forward through requirement gathering sessions. Our training needs assessment was completed with responses from all the active contractors, and this is in reference to the training that we will provide to all project grantees. And we have created a success story tool on attributable impact that can be used in the field by the project grantees to relay anecdotes, any type of attributable impact, and we can use those for success stories. So our evaluation framework is founded on the CDC tobacco control best practices. I talked about that quite a bit in January. And we continue to apply that consistent framework across all the funded projects. And we assess the performance through 4 lenses. And those are fidelity, reach, equity, and outcomes. This structure has been allowing us to evaluate the diverse portfolio of individual projects while also understanding their overall contribution to the statewide tobacco control goals. The value of this framework is in its consistency, and it does allow us to evaluate these very, very different projects, all with the same goal, using a common structure, which supports rigor, comparability, and fairness. So some of our early implementation progress is where the board will start to see that we are moving from transition to planning to execution. The structures that we discussed in January are now operational. We have routine communication, contractor technical assistance, dashboard testing, standardized evaluation plan reviews, data ingestion, and data governance. And these are all the building blocks that we need before we can start interpreting outcomes and presenting longer term impact findings. So the component 4 has moved from that foundational planning into the active contractor implementation. And there's a much clearer approval process across all the different grantees, stronger data collection quality, advancing those dashboard specifications so they're exactly what that contractor needs to monitor their program over quarter and over time, but also allows us that objective view and looking across all projects, and also the practical foundation for the training that we will be giving that is targeted to the project grantees. So this is applying that framework across the diverse contractor mix. And this shows, similar to some of the earlier slides before we came on, just all the different contractors, their status, and the populations that they're serving. So we have the Quitline youth prevention programs, initiatives focused on priority populations. And although these projects are differing in the evaluation framework, as I mentioned, is remaining consistent at a high level across all of them with targeted analytical goals to also produce project-specific findings. And this does help us measure whether or not they're reaching their intended populations that were shown in that chart. The one thing I do want to mention on that earlier that is that the Eastern Highlands Health District has been onboarded since I did that slide after Counter Tools, and we have met with them and we're underway with them. Is the data collection. So our data collection is designed to be layered and low burden to the project grantees. We're using multiple complementary data streams, and again, we focus on not requiring any additional reporting from the project grantees. Our standardized quality reports are providing consistent program measures to the department. We have new survey tools. We're using REDCap, which is just a brand of survey tool to capture success stories, attributable impact, and training needs. We have statewide surveillance data and surveys reviews for additional context. All of these are allowing us to conduct that rigorous, actionable information without overburdening the grantees. Our technical assistance over the last quarter did focus on survey design, measure alignment, data quality, de-identification, secure transfers, and reporting. All right, so now what are we starting to learn? Our early findings are really encouraging. The evaluation framework has been widely adopted, and over the last quarter, our work has helped clarify the contractor readiness, their data quality needs, and areas where that targeted technical assistance is going to be most useful. Our Quitline dashboard development is beginning to show how we can examine both reach and equity, and also reinforces the need to resolve data definition questions before drawing any conclusions. And as we evaluate this diverse portfolio, our focus is on understanding how the projects are collectively contributing to your statewide outcomes and identifying opportunities to strengthen that impact without overstating any type of early results that we're finding. So now we're moving from our, as I mentioned, moving from our infrastructure building to our insight generation. And our focus is on generating deeper insights from the systems that we have in place. And as we're rapidly onboarding the new grantees, we're going to continue to strengthen dashboards and reporting, providing that targeted technical assistance, supporting the new evaluation plan approvals before they're submitted to the department, expanding our data collection and our analysis, and maintaining our strong quality assurance processes. Our infrastructure is functioning, our early insights are emerging, and we are well positioned to provide increasingly robust evidence on program performance and impact over time. Over the next quarter, we're going to continue to work on converting our training needs findings into targeted support, launching the attributable impact and success story tool, expanding our dashboard views, resolving some of the quitline data dictionary and extract questions that we have as we're doing requirement gathering for developing those dashboards, and also advancing the project grantee specific dashboards using their quarterly report data. So thank you so much for your time and for your continued support. We appreciate the opportunity to support the department and have the Tobacco and Health Trust Fund Board, and look forward to sharing all of our future findings as this work continues to mature. Thank you so much.
Thank you so much. Appreciate that, Mary Beth. All right, and then next we have Kathy Boucher from Decker, who's going to be talking to us about the work that they've been doing. I don't see Kathy. Where'd you go? There you are, Kathy. Thank you.
Hi, I'm Kathy Boucher. I'm president of Decker. Alongside me is Andrew Kesson, our SVP of Strategy. So let me pull up my presentation and then share. Give me 1 second. All right, let me go into slideshow. Sorry. Oh, geez. All right, well, it's not working for some reason. Let me just... Okay. Oh, can everybody see it?
Yes.
Okay, great. All right, this is a quick update on where we're at. So our interim campaigns, if you remember back at the beginning when we got this contract, there was a need.
Kathy, I'm sorry. Can I ask you if you could put this in slideshow mode so it's a little bit easier?
I'm trying. Yeah, let me just try it.
I'm going to do it for you, Kathy. I've got it for you.
Oh.
Thanks, Melissa.
You're welcome.
All right, so you want to drive it, Melissa?
Yep, can folks see my slides or no?
There you go. We're there.
Okay.
Yay.
Okay.
All right, next slide. Please.
Now it won't move. Okay.
Front row.
Okay, there we go.
There we go. All right. So our interim campaigns ran from January through April. Early on, we were asked to set aside some funds to drive calls because there weren't any. And so we did a Commit to Quit campaign that got 70% of the budget, and a 30% went to vape free. Those are complete. We'll share top line results. Very busy with consumer research. We finished our qualitative focus groups as well as online quantitative creative testing. Andrew will share some of those results. We continue with our in-depth interviews with health departments and contractors, and then other organizations like CIAC, which we'll talk about in a few minutes. During July and August, we are developing our creative and producing it. For Vape Free CT, we have an 8/4 shoot date. Maura's been very active with us on our casting and location scouting. So that's all coming into fruition. We are scheduled to start for vape free in September. Commit to quit maybe a little bit later, but we are also finalizing media plans. Next. So the interim campaigns, commit to quit, really high engagement levels, a lot of impressions. Again, 70% of the budget went to this. Good number of engagements and KPIs. Next. Okay, so here's what we know from National Jewish Health. What they can't do is tie an action, an enrollment, a call to a specific tactic. So all we can do is kind of assume. So we had 2,422 clicks on the 1-800 quit now. That resulted in 241 callers, of which 54 enrolled. So that's 22%. That's pretty good. We had 3,349 clicks on Enroll Now, resulting in 250 web intakes, which is an 8% conversion rate. Not bad, pretty efficient. Again, because of the timing, we had to leverage existing assets from the prior agency. Next. That's not showing. It's not populating for you. There are a lot of graphs on this page.
Okay, that's because I was given the PDF, so there's nothing I can do about that, unfortunately.
All right. Well, Maura has the PowerPoint anyway. What this is just saying is that the line 80% of the people, the data we got from National, were 35 plus, which is great because that's who we were targeting. Only 20% were under that age. Also, it talks about, the graphs talk about the ethnic breakdown, 68% white, followed by 19% Hispanic, and that was that. Next. Oh, look at your back.
There we go. I found the.
There you go. Those are the pretty charts. Okay. Next. Those are the charts I just talked about. Next. Vape-free CT. Again, only 30% of the budget, so far fewer conversions. However, if we make the leap of faith and say that the 33 individuals who enrolled were because of our campaign, then we're looking at a 40% conversion rate. The other thing I just want to mention here is, you know, one of our biggest goal, right, going into this next campaign is prevention. Get them to not start, right? And then offer them help if they need it. So it's going to be a little bit different next time than like drive the call, drive the text. Next. So Andrew's going to take you through all the wonderful research we've done as of late.
Thanks, Kathy. And Melissa, thank you so much for your mastery here.
Yes.
Appreciate you jumping in. So just a little bit of what we're talking about here. We're finishing up the discovery phase of our campaign. So this is just a little bit of a callback to some results that you've already seen. We did a qualitative survey first with focus groups of a diverse set of the Connecticut population, testing messaging, not spots, not campaign ideas, just campaign communication themes. From that came these for the prevention side: toxic surprise and personal autonomy, the bones of which you'll see underneath: key messages and tone and supporting ideas and themes. I'm not going to go through each and every one of these because this is kind of a quick review we're trying to get to. And then this laddered down into your next slide, which is the cessation, which is the same sort of theory. Again, we're testing themes here in this within these focus groups. So it was be there for good and quitting is hard. Those are the two thematic buckets that we used when we then developed more refined storyboards for our next quantitative survey. So this is what we tested. So this is what laddered down. For the toxic, we came up with these two spots. One was called Wake Up, one was Chemicals. Dramatically, infusing dark humor in both situations, looking to really engage and surprise and entertain so that we could grab their attention and then speak some truth. For the 100% You, it was really focused on performance. What is this doing to prevent you from being who you can be? So those were the two major buckets for prevention. And among those two, it was clear that it's toxic. It outperformed 100% You very, very clearly. And so why they worked, it sort of earned a stronger emotional reaction. The toxic ingredients facts felt new and memorable, and dark humor and shock boosted the attention. Now, I have to say, and one of the reasons why 100% You wasn't necessarily didn't do as well, we came to realize was because more because of the execution itself than necessarily the theme. So I'll get back to that in a sec. Thanks. So then on the cessation side, we tested Be There for Good, and what it costs was a spot where it was a very emotionally charged spot where someone is paying for their tobacco products with family members, with photos of family members. And quitting is hard. We came up with sort of a clever way of using the word quit. It became very clear that people were not engaging with the word, were not enjoying or appreciating the word quit. It had sort of changed the tone for them. It made it feel as though we were preaching. And it was also fairly confusing. So what it cost and Be There for Good, that was a thought-provoking spot that really seemed to communicate well. And by the way, the way these were communicated, you'll see these little thumbnails here. There's a storyboard, and then this is a video of our creative director basically walking them through the storyboard. So that was our methodology that we used across the board. Next, please. Thanks. So what it cost was clearly the most salient cessation concept for nicotine. Again, quitter was confusing. It didn't resonate in the way that we wanted to. So it was very clear. It was very clear that was the direction that we wanted to go. So why? It was, again, emotional storytelling. Family life moments were framed in a very powerful way. And it was less gimmicky and more authentic. Additionally, this was a spot that had the same consistent tone as our prevention side. So it began to really strengthen the overall campaign. So then what do we do with this? So what we've decided to do is double down on what tested the strongest. So what we're doing right now, we're into production, is we're trying to produce, we're going to produce Wake Up and Chemicals both. And then in addition, as I suggested, since that performance piece, the 100% You really did perform well in our phase 1 of research, we felt like we didn't want to leave that idea behind, but we wanted to address it in a way that could be more universal, not just speak to athletes, which is what our original execution had done. While this will also include athletes, it has room for other territories like drama and music and such. So it has the ability to scale exponentially. In addition, if we do, I'm sorry. In addition, I'll just no, it's all good. Again, it brings that all together. So okay, so then with cessation, what are we going to do? Well, we notice CDC funding requires that we use their creative. So that's what these thumbnails are on the right there. You'll see that's what those spots are. But should the funding come through, we are looking to extend the emotional journey. We're looking to pull the cessation piece into our overall campaign with what it costs as well. Kathy, did you want to speak to that a little bit?
Yeah. So what it costs, like we'd need extra funding to produce it and place media. But I want to bring up a couple of other items because we've been digging deep that would require additional funding. So we did an in-depth evaluation of commit-to-quit-CT.com and date-free-CT.com. And there's a clear need to first optimize them for SEO. They currently score like 26 and 27 out of 100 in the domain ratings. And if you think about that, compare that to CTDPH and CDC, which are in the 90 out of 100 range. That's one. The second part is that we need to make both sites compliant for the new Department of Justice ruling that you have to follow WCAG AA standards for accessibility. So we need to revamp those sites to meet those standards. Those standards aren't in effect or aren't required until April of 2027, but we're going to start now. We'd like to start now. It's not a short process. Now, that doesn't just include websites, that includes every digital asset we produce, right? The color contrast, captioning on every video. So there's a lot of work to be done. So in addition to really wanting to produce this, what it costs, we really want to get the websites in the best shape they can be. So,
right.
That's that.
So another piece of what we're doing are these discovery interviews. Now, what this is going to lead to is a lot of the supplemental material and assets that we're creating around the campaign. So not necessarily for the direct advertising campaign itself, but toolkit items. You know, what do these folks need? Things that can be posted on the websites that that Kathy just spoke about. So we spoke to the American Lung Association. I believe we spoke to them actually just right before our last meeting. We're looking to them for a variety of things. In fact, what we're planning to do with all of these is re-engage after this discovery period is done, and we've gotten further along in our toolkits. How can they help us disseminate them? We're also looking for the ALA specifically to help us sharpen that media targeting when they bring back that study, I think, which is going to happen early fall, I believe. Next slide, please. We also spoke to the Bridgeport Health District. Again, learning more about what they can use and what their actual practices are. Again, we plan to re-engage once we're further along in our toolkit development. Middletown is interesting in particular because they've taken on cessation efforts in-house. Without that much momentum, quite frankly, right now. So we're talking to them about how we might be able to help support what they're doing as well. And then finally, yeah, Kathy alluded to the CIAC. We're very excited about this partnership. So what we're doing is DPH is going to have a presence at a variety of different sporting events around Connecticut. In addition, we're really leaning on them for peer-to-peer advocacy. We're going to activate student ambassadors, not just athletes, but we'll be able to have a presence and/or speak and at the National Honor Society meetings, High School Leadership Conference, and Empowerment Day. So we'll have these ties into these youth leadership groups. So we're looking forward to the potential here. It's in some ways we're looking for them to provide us with a sort of an informal influencer campaign as well. And we're going to provide strict guidelines around, what we're looking to do in terms of messaging on behalf of CTDPH. So that's where we're at so far.
Thank you so much. Appreciate hearing that both from both of you. I think that one of my favorite pieces in there was around the work that you all were doing with CIAC, and particularly how you're incorporating the youth to speak to other youth. I thought that was pretty fascinating, particularly since the research showed that that was far more effective versus having college students try to speak to high school students and high school students speak to middle school students. So thank you for that.
Yeah, we're very excited by that potential as well.
All right. And then we have one more presentation today. So internal to the department, we have Suruthi. Oh my goodness, sorry about that, Suruthi. I'm going to mispronounce your last name. Abraprudi. Did I say that correctly? All right, thank you. So she's going to be doing some a data presentation from internal to the department.
Thank you, Deputy Commissioner. Good morning, everyone. I'm Shruti Abrapudi, an epidemiologist too at Connecticut Department of Public Health. I'm going to present Connecticut adult and youth data and trends. Let me quickly share my screen. Okay. Okay. So today I'm going to talk about adult tobacco use, high school tobacco use trends, a short summary of findings after a brief introduction of our data that we used. We used Behavioral Risk Factor Surveillance System, also called BRFSS, for adult tobacco data. It is an annual health-related telephone survey conducted nationwide with 400,000 adult interviews. It is conducted by Centers for Disease Control and Prevention, CDC, in collaboration with state health departments. Here, adult data shown here are tobacco use, cigarette use, cigar use, e-cigarette or other electronic vapor products use. Next up, we used Youth Risk Behavior Surveillance System, also called YRBS, for the youth data. It's a national survey that tracks health-related behaviors and experiences conducted by CDC in collaboration with state and local education and health agencies. Youth data shown here are tobacco use, cigarette use, cigar use, e-cigarettes or other electronic vapor products use. And lastly, nicotine pouch usage. Questions on nicotine pouch usage were added for the first time in our 2025 survey. For the national data comparisons, we used Youth Tobacco Survey. Here we have the tobacco usage of adults. Overall, the rate of adult tobacco use is 16.8%, representing approximately 450,800 adults. Men are significantly more likely than women to use tobacco. Current tobacco use is significantly higher among adults aged 35 to 44 and 18 to 34 than among those aged 55 plus. Because of low sample size, comparisons by race and ethnicity are not made here. High school students' tobacco usage. Overall, the rate of youth current tobacco use is 14.9%, and it represents approximately 24,300 high school students in CT. Nationally, the rate of youth current tobacco use is 9.5%, representing approximately 1.5 million high school students. Females represented 15.8% and males represented 14.1% in Connecticut. Current tobacco use is significantly higher in grades 10, 11, and 12 than in grade 9. Coming to tobacco usage trends, for adults, tobacco use decreased significantly between 2015 and 2024 from 19.9% to 16.8%. However, there was no significant change between 2023 and 2024. For high school youth, there was no significant change in the rate of use between 2015 and 2025 or between 2023 and 2025. Next up is cigarette use. Overall, the rate of adult current cigarette smoking is 9%, and it represents approximately 241,400 adults. Nationally, this rate is 11.5%. Current cigarette smoking is significantly higher among adults aged 45 to 54 than among those aged 18 to 34. Because of low sample size, comparisons by race and ethnicity are not made here. Coming to cigarette usage, for high school students, overall, the rate of youth current cigarette smoking is 3.3%. It represents approximately 5,400 high school students. Nationally, the rate of youth current cigarette smoking is 1.8%. This represents approximately 280,000 high school students. Because of low sample size, comparisons are not made here. Cigarette smoking trends for adults. The rate of cigarette smoking decreased significantly between 2011 and 2024 from 17.1% to 9%. And it did not change significantly between 2023 and 2024. For high school youth, cigarette smoking decreased significantly between 2011 and 2025 from 14% to 3.3%. However, it did not change significantly between 2023 and 2025. Cigar usage. Overall, the rate of adult current cigar smoking is 4%, representing approximately 100,400 adults. Because of low sample size, no comparisons have been made here. Cigar usage for high school students. Overall, the rate of youth current cigar smoking is 2.8%. It represents approximately 4,500 high school students. Nationally, the rate of youth current cigar smoking is 1.2%. It represents approximately 190,000 high school students. Again, because of low sample size, comparisons are not made here. Cigar smoking trends. For adults, the rate of cigar smoking did not change significantly between 2015 and 2024 or between 2023 and 2024. For high school youth, there was no significant change in the rate of cigar use between 2015 and 2025 or between 2023 and 2025. E-cigarette or other electronic vapor products usage. Overall, the rate of adult e-cigarette use is 5.6%, and it represents approximately 148,700 adults. Nationally, this rate is 8%, and because of low sample size, no comparisons have been made here. High school students' e-cigarette usage. Overall, the rate of youth current e-cigarette use is 12.2%, representing approximately 18,900 high school students. Nationally, the rate of youth current e-cigarette use is 7.1%, representing approximately 1,130,000 high school students. Students in grade 10. Students in grades 10, 11, and 12 are significantly more likely than those in grades 9 to use e-cigarettes. E-cigarette usage trends. For adults, the rate of e-cigarette increased significantly between 2013 and 2024 from 3.7% to 5.6%. However, it did not change significantly between 2023 and 2024. For high school youth, e-cigarette use increased significantly between 2013 and 2025 from 5.3% to 12.2%. However, this did not change significantly between 2023 and 2025. Nicotine pouch usage. Overall, the rate of youth current nicotine pouch use is 2.4%, representing approximately 3,800 high school students in Connecticut. Nationally, this rate is 2.3%. It represents approximately 350,000 high school students. Again, because of low sample size, no comparisons have been made here. Summary of findings. Based on our 2024 BRFSS and 2025 YRBS, 16.8% of adults and 14.9% of high school youth currently used some form of tobacco, including cigarettes, cigars, e-cigarettes, smokeless tobacco, hookahs, or water pipes. For high school youth, nicotine pouches was newly added to 2025's YRBS survey, and this is also included in current tobacco use. Since 2015, tobacco use among adults has decreased significantly, while among high school students, the rate of use has not changed significantly. Among adults, in 2024, cigarettes were the most prevalent form of tobacco used, which represented 9%. Among high school youth in 2025, e-cigarettes and other electronic vapor products were the most popular tobacco product, which represented 12.2%. For both adults and youth, current use of cigarettes has decreased significantly since 2011. Among adults, it decreased 47% from 17.1% to 9%, and among high school students, it decreased 76% from 14% to 3.3%. In 2024, e-cigarettes and other electronic vapor products were the second most prevalent form of tobacco used by adults, which represented 5.6%. The rate of e-cigarette usage increased significantly between 2013 and 2024 from 3.7% to 5.6%. Since 2015, cigar smoking among adults and high school students has not changed significantly. And thank you. I'll be happy to answer any of your questions.
Thank you. I'll pause so that the board members can take stock and raise their hands for questions. And I see a few of them already have their hands up. So I'll start with Representative Cindy Harrison. If you go first, please.
Thank you. My question about cigar smoking, and I'm not sure how we phrased the question. I know that there's a certain element of, they get together for a party and they have a cigar and it's sort of like this cool thing to do, and that doesn't necessarily make them a cigar smoker. So how did we phrase the question to capture that data?
Okay. I can quickly answer. I can pull up the question for you.
I just want to make sure that we're capturing true cigar smokers versus, the cool thing to do at a party one time,
I'll answer that, Ruthie. So the question was asked during the past 30 days on how many days did you smoke cigaretto, a lot of cigars, and it gives some examples, and it has a range of days, like 0 days, 1 to 2 days, all the way up to all 30 days. So doesn't specifically say that occasionally used, but I think it asked for 30 days, how many days you used it.
So we may have a little bit of a jumble in there, you're thinking.
It's possible.
Yeah. Okay. Just a question. Trying to sort out data. Thank you so much for the answer.
Sure thing.
Thank you. Anne?
Yeah, thank you so much. And thank you, Shruti. That was a really informative presentation and well done. I just had one question about the, first of all, it was nice that the youth survey included nicotine pouches. But I'm wondering, it looks like maybe the BRFSS for adults didn't ask that question, or at least you didn't report on that. So I'm wondering if there was data about adults using nicotine pouches.
So the data that we represented here is from 2024. For BRFSS, we added this question in 2025. So possibly next year we might have that data in BRFSS also. And we might have the data by the end of this year, or yeah.
Great, thank you so much.
Of course, thank you.
Representative McCarthy-Vahey.
Thank you so much, Claudio, and thanks to all of you board members for doing this. And this presentation is wonderful. Forgive me, I didn't realize I wasn't muted when I made the comment I did earlier, which was we seem to be much higher than the national averages for youth. And I was paying closest attention to youth stories. And I wanted to just ask or have you comment on that. Seems to be the case. Of course, I'm wondering if that's because we spend so little of our master settlement dollars on the prevention, because as Claudio knows, that's certainly my bias. But I'm not asking you to make that connection, but it seemed in every category that this was the case, that we were not insignificantly higher than those national averages. Am I right about this?
Is this in regards to nicotine pouch usage or e-cigarette?
We're all, and just looking at quite a few of the categories.
Yeah, so to compare with national average, we are somewhat there. The numbers are similar, but to compare them significantly, we'll have to look at the confidence intervals and answer that question. But I would say maybe yes.
So I took some screenshots and let's see, I'll go back. Here's one, just the percentage of high school students who currently use tobacco, and the overall rate of current tobacco use 14.9%. High school students in Connecticut, nationally, the rate is 9.5%.
Yes.
So am I hearing you correctly? Is you said we'd have to go back and look at the confidence on that?
Yes, if I'm right now looking at the confidence interval, and it says that Connecticut usage is significantly higher than national usage, which is 9.5%. So I think yes, Connecticut usage is overall it's higher for overall tobacco usage.
And for e-cigarettes or other electronic vapor, it's 12.2 versus 7.1%. Also pretty
yes, for
significant.
e-cigarettes. Yes, Connecticut average, which is 12.2%, is significantly higher than national average. So yes, yeah.
Claudia, would you be okay if I'm sorry, Rep. McCarthy Vahey, I wanted to also be responsive to your comments about what are we doing, right? Because those are concerning numbers. And Claudio, if I'm not stealing thunder from other discussions that we're going to have, can I address that in talking about our strategy moving forward on this? All right.
Perfect teeing up. Thank you.
Thank you, Claudio. So Representative McCarthy Vahey, so this is something that we actually were discussing, and Claudio and I had a sidebar conversation about this, because when you see some of these numbers, they are pretty startling, and you're wondering, what could we be doing better? How have our investments been working? And before you had joined, one of the things that I had mentioned that Claudio and I were talking about, because it's not just about setting up the contracts and getting funding into the communities, but it's the return on the investment, right? Like, what are the dollars actually investing? So what we've been talking about is that using some of the funds to do a carve out, to do a strategic plan, to address some of the findings that we are seeing, and coming up with an overall strategy and building an evaluation into the beginning of that, not just to evaluate how the individual contractors are performing, you know, contractually, but how does that impact our overall return on investment? Are we able to show that all of these different interventions are actually tracking back to addressing these root problems that we've been able to document with all of these surveys, to really make sure that we are taking a closer look at directing those dollars towards prevention up front, so that we're not seeing that because this is an area that I don't want to lead the pack on. I think we're all in agreement that in Connecticut, we like to be innovative, we like to lead the pack, but these are not areas that we want to be leading the nation in.
Well, thank you for that. And I've been off camera most of the time, and I was late to the meeting today, but I will tie back to something, and Claudio and I have talked about this too, which is the CIAC, for example, partnership and the youth voices. A lot of our regional behavioral health action organizations and our local prevention councils that connect in with DEMIS, they have youth groups and organizations. I think that's another way to leverage this. And then I also think about, how are we tracking and evaluating what some of those dollars that are going to the regional behavioral health action organizations, how, you know, what kind of evaluation and impact are we seeing in conjunction with the work that's being done here? And then one other just comment, or maybe a question, and this was Anne asked about the nicotine patches and the youth risk behavior surveys as our youth population I know it looks like we're, getting new data going forward, but boy, just anecdotally, it seems that our young adult population, 18 to 35, are really the ones, it's being certainly put out into the manosphere. For example, young men who I see those walking around with those round tins in their pockets, and that I'm really interested in us just seeing and learning more. So I'm really grateful that you're continuing to explore that too. And just again, can't say thank you enough for the work that you're doing. It's life-saving, all of you.
Thank you for that. And I also wanted to highlight the work that Maura Fitzgerald has been doing with Decker and all of the folks there, because what you just said also speaks to the fact about why it was so important to do all of the work on the market research to how do the messages actually align with how they're perceived, and having different messages for different age groups and all of those pieces, and then measuring the effectiveness, right, of that messaging. So I just wanted to also highlight that, but how important it is to layer it. So in working with, the community behavioral action groups, working with marketing, working with all of the different community organizations, it truly is work that, has to be approached with a 360-degree lens. And just once again, wanted to just say, how much your support, Senator Anwar's support, really has meant to making sure that we do have those dollars available to do those things, like doing that market research and pulling in the youth early on before we designed this campaign. So just wanted to acknowledge that.
Thank you. And may I, Claudio, with your indulgence, make one other quick comment? Just in full, transparency and extroverted mode. I and others have been talking about getting together with some of the key legislative leaders. Obviously, Senator Anwar, who I think just joined, is a huge champion and partner as co-chairs on public health. This is something we care a lot about, but wanting to talk with some of our other legislative leaders and advocates ahead of the next legislative session to look at what some of the top priorities are for us to align and support the work that you all are doing here.
That's terrific, and we welcome that. And maybe at that time we may even have a little bit more data and evaluation from our evaluators that could tee up that conversation of what seems to be working and what are some of the state trends, just to provide that level set. So happy to partner with you. I think the work that we do here is great because it's sort of the direct fulfillment of investing in community. But if we can take it to the next level and actually inform policy change or broader based action that's sustainable, that's even better. So thank you. Suchitra, you have a question?
I actually have more of a comment in the spirit of being forward thinking, like Representative McCarthy was just stating with regards to ONPs. I don't know if any of you are involved in creating the BRFFS or the YRBS assessments. My suggestion would be definitely try and get some questions in there about the use of products like e-cigarettes to use other substances, because I just attended an end-use, National Drug Emergence workshop, and they were talking about how these products are being used with K-pods to administer ketamine. They are being used to administer DMT. They are laced sometimes with nicotine, sometimes without. They are available with cannabis, with nicotine. So there's just this whole market that's emerging, and who uses these products the first, these new products? They are youth. They are the ones who try them out. And this, in fact, is very scary to me, and something that I had cautioned about like 20 years ago when these products first came out, that they are essentially drug delivery devices and they could be used to administer a wide variety of things. Anyway, no one listened then. Hopefully people will listen now.
Okay, that's good feedback. I think that concludes the discussion and questions related to our evaluation and presentation. So thank you, DC Morrissey. Thank you to the presenters. It was very helpful. And that brings us, I think, to, I'm going to turn it to Melissa and Sharika, also with the assistance of DC Morrissey, to begin teeing up the statutory charge and framing up our allocation votes today. Melissa?
Sure. Thank you, Claudio. So we are just going to start as a means of reminding us of our statutory charge as we go to do our allocation plan of what is this board tasked with doing. And so a reminder that the purpose of the trust fund is to develop programs that and to reduce tobacco and nicotine use through prevention, education, and cessation programs that use evidence-based best practices regarding, and here's where you'll see the CDC categories that Connecticut codified in statute. So we must utilize our Tobacco and Health Trust Fund funding to support state and community interventions, communication methods to disseminate health information to a wide audience, cessation interventions, surveillance and evaluation, infrastructure administration, and management. And the board is also charged with supporting the reduction in use of all tobacco and nicotine products, including but not limited to combustible, non-combustible, electronic and synthetic tobacco and nicotine products. So a wide range there. We also in statute, the board has four main priority areas in which we must prioritize our funding. So once we set our allocation plan according to the 5 CDC categories, which is what we're going to vote on and do today, and we move into the RFP development process, that RFP development group and evaluation committee will need to be mindful that our board's priority areas are the prevention of initial tobacco and nicotine product use among youth and young adults, smoking cessation directed at adults and youth, elimination of exposure to secondhand smoke and aerosol, and identification and elimination of tobacco and nicotine related disparities. And then finally, and this will come into play later as we have this discussion, the board is also tasked with considering the availability of private matching funds and recommending the disbursements from any of the trust funds in addition to any other private funds that we should bring in that would otherwise be appropriated by the state for such purposes and programs. So a lot of words to say that we also are tasked with trying to find private and other sources of diversified funding. So with that, I am going to turn it over to my colleague Sharika, who is going to walk us through the recommended allocation percentages. Sharika.
Thank you, Melissa. Okay, so here is a visual pie chart showing the percentages of the CDC best practices that Melissa just outlined on the previous slide. Okay, now we're looking at the available balance for the FY26 allocation plan. This includes the $12 million annual disbursement, in addition to the $1.4 million of accrued interest shown highlighted in light blue here, as well as the $2.4 million that was unallocated for cessation interventions during FY24, bringing us to $15.9 million available for FY26. Now moving along to the FY26 allocation breakdown of the CDC best practices with the Connecticut allocation reflecting the unallocated FY24 funds and accrued interest. The table shows the CDC recommended funding categories and the corresponding percent allocations. With that, the allocation amounts based on the $15.9 million available. State and community interventions is allotted $5.5 million. Mass Reach Health Communications is allotted $1.9 million. Cessation interventions is at $6.3 million. Surveillance and evaluations, $1.4 million. And infrastructure, admin, and management is allotted $639,000. Again, here's just a visual pie chart showing the percentages of each CDC recommended category that I just went over on the previous slide. And the last slide here provides some examples provide some examples of CDC best practices for each component that you can refer to. And it was great to hear some of these examples today are from Mass Reach Health Communication, Surveillance, and Infrastructure and Administration. That concludes the presentation slide deck for the FY26 allocation plan, and I'll turn it back over to Claudio.
Thank you, Sharika. I guess it's pretty straightforward. This is sort of our third time doing it. And I appreciate that when we did the statutory change, we've sort of laser focused our investments on tobacco, nicotine, and nicotine related products. It sort of has kept the focus of these investments so that it doesn't bleed to trying to do more than we're really statutorily charged to focus on. So it makes days like this a little bit easier because we have clear guidance from the CDC that's been validated and re-upped by DPH, who agree with the distribution and the allocation here. The only thing, and we've already talked about it at the top, but the change that we're making is not in a percentage case, but to fully take advantage of the new independent evaluations and the people that we brought in to help us frame up a 5-year plan on tobacco control. We're recommending that part of that 4% of administration and infrastructure be to seat a durational person at OPM in conjunction with DPH, where we would actually look very thoughtfully at some of the lessons and feedback from the evaluations and try to make a more comprehensive plan. And part of that durational person's responsibility will also be helping to provide technical assistance and use the great ROI that we're able to demonstrate for some of our grantees in leveraging additional grant opportunities. So I think some of our nonprofits and smaller groups that come in for grants under our program can really benefit from a packaging of how the dollars and investments into their programs have actually yielded major results. And I think that that hopefully will help them all leverage additional resources to magnify and amplify the work of tobacco cessation and tobacco control in our state. DC Morrissey, I don't know if you want to say anything more on any of these big topics before we open it up, and then we can take a vote once people have all their questions answered.
Thank you, Claudio. I think you captured it well, and anything that I have to add would be redundant.
Great, thank you. And then the only other thing I will add is just a reminder that statutorily, we have a little bit of flexibility to move between line items once the legislature approves, but that flexibility is limited to plus or minus 10% or 50,000, whichever is less. So in many cases here, we're looking at the firm $50,000 cap would be our limitation to move between lines. Any comments, questions, feedback from the board? Dr. Salner.
Claudia, thanks so much. Just looking back at the last couple of years to see how the allocation percentages we've approved have gone along with what we've accomplished to date, are we pretty comfortable that the CDC best practice guidelines, kind of match our best use of dollars? I don't know if we've been doing it long enough to ask that question, but just trying to learn from what we've done with the last allocations to make sure that the CDC best practices still align with where we should be heading.
It's a great question. And so I think I'll answer it and I'll let DC Morrissey add in. I think part of it is we're actually, one, statutorily, as we're prescribed right now, we have to follow the CDC guidelines and best practices, but there is this sense that, it hasn't been actively refreshed in a while. And although we don't have reason to believe that there's radical difference in the guidance, should we sort of build it from the ground up today, I think this is what DC Morrissey was wanting us to do, is actually when we now have some experience of a few years and having these new evaluations on board, maybe we can make more of a refined or nuanced allocation plan and 5-year plan, and then actually peg to that and whether it makes more sense than some of the CDC standards that have been in place for a while. But I'll let DC Morrissey maybe add on to that comment.
No, that was well said, Claudio. And I think what I'll do, I will actually ask Amy if she can come off of mute and talk about this. We've had significant discussions about this internally, and Amy spent a lot of time talking to other states and hearing what they're doing as far as the CDC guidance. Amy, can you add some more color to this for us?
Sure. Amy Marizzi, Chronic Disease Director at Connecticut Department of Public Health. The CDC best practice guidelines do date back to 2014, but they are still looked to as the best baseline when designing investments for comprehensive state tobacco control programs. They did release some topic-specific evidence-based guides, CDC did, between 2019 and 2021 that still reference back to those guidelines. So it's seen as a relevant starting place across the country, despite the fact that it's over 10 years old. But certainly a starting place, and then states do take the liberties to kind of review their activities and make slight adjustments or significant adjustments depending on what they learn about their own landscape.
Thank you, Amy.
You're welcome.
Next,
Yeah, a question in that
Sushitra.
regard. Thank you so much for that. I just had a question in that regard. Considering that the CDC Office on Smoking and Health has been eliminated, has your work been impacted in any ways? You know, is there? I've heard from other states that they often seek guidance from the CDC Office of Smoking and Health, and they have not been able to get that guidance, and it has impacted some of their work. Does that apply to us in Connecticut? I was just curious.
So I'll take that one. Thank you. So I would say that we've seen across the board in the agency, depending on which function of CDC we're talking to, that there has been some interruption in communication, but overall, the vast majority of like the bigger programmatic questions, we are able to get answers. And, you know, I commend, you know, Commissioner Giuttani, our legislators, the governor in this, that early on when we were starting to see that there was some fluctuation in some of the policy shifts at the federal level, we were empowered to make changes here at the state level so that we were less reliant on some of that guidance and feedback. So most of the reliance that we have now is more for the fiscal administration of those programs. When we're really talking about how are we actually designing policy, how are we implementing these programs at a state level, that resides within the state. So that's less disruptive to us. So I really, like I said, I have to commend the amount of forethought that went into really thinking about how we would move forward in an environment where we could be less expectant of support from the federal government, or that there might be interruptions based upon staffing availability.
Thank you.
All right. If there's no further questions, we're going to take a series of 2 votes. The first vote, and I'll entertain a motion on this in a minute, is to vote on the allocations by category. And the goal is to vote on the CDC categories as it is in statute and as we've just discussed here on the slide, with an allowance of the plus or minus 10% per category, or no more than $50,000, whichever is less, which is also a statutory flexibility that we would build into our allocation plan. Do I have such a motion on that?
So moved.
Moved by Dr. Salner. Do I have a second?
Second.
Seconded by, can you just please state your name?
John
so I have it on
Picardo.
record? Okay, thank you, John. So the motion is properly moved and seconded. Any further discussion on approving the allocations by categories based on the CDC categories with that plus minus 10% flexibility or $50,000 threshold? Seeing no discussion, I'll entertain a vote. Let's vote by saying ayes or nays. All those in favor of approval, please signal by saying aye.
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 Any opposed, signal by saying nay. Seeing none, the motion is carried. So ordered. We'll make that and put that into our allocation plan. The second vote that we need to take is on what to do with the RFP processes and admin. So my recommendation, and what has been the historical practice of this board recently, is that other than the directed administrative costs, which are not put out to RFP, but granted and designated to DPH, and in this case, DPH and OPM, would be written as dedicated earmarks within the allocation plan, and then everything else would be subject to a competitive RFP process. We've typically liked that because it allows for maximum participation. It's a very transparent process, and we ensure that we're getting the best bang for the buck through a competitive RFP procurement. So our recommendation would be that we continue that approach. DC Morrissey, the only flexibility I would like the board to consider is that if there's a period of time where we may need to extend our evaluators while we formalize a subsequent RFP, that might be prudent. So your thoughts on that piece before we ask the board to weigh in and vote?
Absolutely agree on that. And I would stress the importance of having consistency across all of the contractors. So not having that gap, plus ensuring that we're doing evaluation uniformly throughout the process would be very important. So you have our support in that as well, Claudio.
Okay. So then can I ask for a motion that we go to competitive bid for all the categories and interventions except for the administrative 4% and any bridge funding that's needed to make sure that we have a consistent evaluator on board?
I'll move that, Claudio. It's Ann Foley.
Thanks, Ann. A second?
Second.
There's a second from Dr. Sellner. Any discussion? Seeing none, we'll take a vote. All those in favor, please signal by saying aye. Aye.
Aye.
Any opposed? Seeing none, so ordered. And that concludes our two major votes for today. And just a reminder, what we will do now is formalize those allocations into a written narrative and to the allocation plan for transmittal to this board. You'll see the draft in September. We'd invite you to give feedback, edits, share your red lines with that. Once we compile all that, we will plan to send a formal transmittal to the General Assembly in October. That will go to both the appropriations of the Public Health Committee, which have cognizance and have an ability to hold a public hearing and vote on approval of the plan. And if that happens, we'll certainly keep you all aware of the public hearing and your ability to testify and or submit comments and support. With that, I want to oh, sorry, Ann, go ahead.
Thanks. I just had a question about the competitive bidding. Will there be an opportunity again this year for board members to participate in that? And if so, what's the time frame that we might expect that to happen?
Yes, so as has been past practice, I know DPH leans on disinterested board members, meaning if you don't have a conflict of interest, you're not working with an organization that may bid, we invite board members to be part of that evaluation panel. It's been extraordinarily helpful. I know that many of the panelists who scored our RFPs in the past two rounds came from this board. So DC Morrissey, I imagine we'd continue to make that offer to our board members. Probably looking at, and I'll leave it to you for like when that solicitation and when the evaluation panel may convene, but I suspect it's still a little ways off since we need formal approval from the legislature and then begin crafting the RFP. So do you have any sense yet of early timeline?
Not yet on our side, but we can get that information back out to the board through Melissa shortly. I know that the team is doing some background work on to do like the boilerplate elements and going back and using some of the data that we've already collected to shape and inform how the process will move forward. So hopefully we'll have some information shortly.
Thank you.
Excellent. Thank you. So that brings us to public comment, and I just want to recognize that as has always been the case, we are blessed to have really strong, vocal, and active allies, both legislative and stakeholders. One of those, Representative McCarthy-Vahey, I know we heard from earlier. I also want to recognize on the call, we have Senator Anwar, her co-chair on the Public Health Committee, Bright Johnson, who's been there from the beginning to make sure that this issue of tobacco cessation funding is taken seriously and that the board continue to do good work. And I know he's a champion at the legislature. But I want to, in addition to recognizing them and thanking them for being active and attending, pause to see if any of them want to make public comment.
I just want to say thank you so much, Mr. Chair. Thank you so much for everyone's time and the good work we are doing. Prevention is better than cure, and the more we do, the better it is. It saves lives. It's proven. So thank you.
Excellent. Thank you. Any other members of the public wishing to speak? Seeing none, I'll close the public comment. Then the last item for business is a motion to adjourn. Do I have such a motion?
So moved.
Thank you, Dr. Salner. And a second?
I'll second it, Claudio.
Thank you, Ann. Motion is approved, is made and seconded. The time is now 12:11. Motion to adjourn. All those in favor, please signal by saying aye. Aye.
Aye. Aye.
All right. The ayes have it. You're all free to go and enjoy lunch. Thank you for all you do, and thanks for our conversations today.
Take care.
Thank you, everyone.
Thank you.
Yes.